Hi, my name is Joy Ho. I am a hematologist from Royal Prince Alfred Hospital, and I'm delighted that Myeloma Australia has asked me to give a presentation on myeloma side effects and strategies to improve quality of life, which are very important aspects of myeloma care, and that oftentimes we may, in the process of aiming for efficacy of treatment, may pay less attention to. And it is my role today to address these specific issues to help our patients, as well as some of our nurses and doctors who may be interested in this, to concentrate on the importance of quality of life. May I say that I am doing this talk in close collaboration and with the fantastic assistance of one of our staff, Professor Tracy King, who is our myeloma clinical nurse consultant. I also want to thank Professor King for her support of this talk with some of her slides. So let's first of all look at how myeloma affects individuals or patients who may have different manifestations. The main disease manifestations of myeloma are summarized on the left, and in fact, they are in the ways in which we often use to make the diagnosis of active myeloma. So here you can see the mnemonic of Crab, and you will see on the left, under those categories, that we have explained in a little detail as to how these symptoms and signs can occur in myeloma patients. Other features down below are also very important, and they include spinal cord compression because of the impact of myeloma on the spine, the second one being recurrent infections, and thirdly, being hyperviscosity symptoms, resulting from the fact that myeloma makes a paraprotein and can make the blood very thick, leading sometimes to symptoms such as confusion, reduced consciousness, and so forth. However, within this context of having these symptoms and signs, on the right, you will see that there are other diagnoses that can lead to, for instance, high calcium, renal impairment, anemia, and bone pain. And so it's really, therefore, important for us as doctors to keep an open mind as to the causes of these symptoms and signs. So in looking at quality of life, one of the key issues is that we have to balance the efficacy of our treatment and the side effects. So obviously, treatments can cause a range of side effects, which are often predictable and manageable. And that's why it's important to go through them, as I'll do in a minute. And they vary in intensity and duration and can be cumulative. By understanding the side effects of your treatment, it will help you to manage and cope with them better. In addition, sometimes we often forget that it's helpful to have someone who is coming along with you on the journey of myeloma to be able to discuss with both yourself and with us as doctors what the symptoms are. It is often our experience that patients try their very best to cope with treatment and therefore may underreport their symptoms, and hence the carer serves as a truth teller. In many ways, this then, in reporting the issues in a timely manner, can assist patients to become more adherent and also help them to tolerate treatments better. And in addition to age and other comorbidities, meaning other conditions that a patient might have, there are other things that can influence how severe side effects can be. This includes how many lines of treatment and how long they have had the treatment for. We are aware that usually toxicities are particularly significant in the first 2 to 3 cycles of therapy, and they often then at least become more mild and more tolerable. Differences can occur between whether different agents are used in combination or whether it is a monotherapy or single agent. And often concurrent or compounding toxicities of previous lines of therapy can add to the side effects of the therapy that a patient is undergoing at the present time. Of course, we often talk about performance status, and that basically means how well a patient is overall. And this in turn relates to frailty and disability. So I'm now going to look at the most common myeloma drugs and explain some of the common side effects. So the first being bortezomib, being a proteasome inhibitor, which is given once or twice a week, but mostly once a week nowadays. It's often given with dexamethasone and with an antiviral, such as valacyclovir or acyclovir, because it has an increased risk of shingles. And here you can see some common drug partners that is used together, which can augment the side effects. But on the right, in addition to seeing that increased risk of shingles, one of the key side effects, which may require dose adjustments, is peripheral neuropathy, which I'll speak to in greater detail in a moment, as well as lowered blood counts and diarrhea or constipation, sometimes which can be alternating. The next slide, likely familiar to many of you, is lenalidomide being widely used. This is called an immune modulator. It's a tablet. We tend to advise patients in terms of enhancing the quality of life to take it at bedtime because it reduces the somnolence that can be associated with lenalidomide. Because it can lead to thrombosis or clotting, we would usually use a blood thinner. In the case of aspirin, it actually inhibits one of the cells in the blood called platelets. And in certain patients, especially those who have a high risk of clotting, we would actually use a specific anticoagulant. There's a question mark before Resprin. This word, this is a drug which we use to prevent a particular type of pneumonia called pneumocystis. And so there's varying use of Resprin as a preventative antibiotic to prevent this particular type of pneumonia. Additional side effects include rash, which often occurs at the start of therapy. Again, lowered blood counts, which can be associated with infection. As I already mentioned, increased risk of blood clots. But peripheral neuropathy is more rare than bortezomib, which I mentioned before. However, chronic diarrhea is a very well-known long-term side effect, and I'd like to look at that in greater detail in a moment, as well as fatigue. A related drug to lenalidomide, because it's in the same group, is pomalidomide, which is also a tablet. And we often also, for the same reason, ask patients to take it at bedtime. The issues with blood thinning is also there. And on the right, you can see that the side effects are actually similar to what I've mentioned for lenalidomide, with different, similar as well as different drug partners. So I've mentioned peripheral neuropathy several times now, and I'd like to concentrate on that because it is a very important side effect that affects quality of life. What is peripheral neuropathy? It's basically the damage or inflammation or degeneration of peripheral nerves. And on the right-hand side, you can see a diagram showing what is the central nervous system, which is the brain as well as the spinal cord, as opposed to the peripheral nervous system, which is all these nerves which ensue from the spinal cord and supply the rest of the body. This damage or inflammation can lead to changes in the way they work, these nerves work, leading to changes in how we feel or how we move or how we function. And as a result, we call the neuropathy either sensory in terms of feeling, motor in terms of moving, but also autonomic, which affects our bodily functions. And I'll come back to this in a moment, but autonomic, for instance, may lead to changes in blood pressure, which can be significant if patients have a severe autonomic neuropathy. The sensory neuropathy often starts at the fingertips and toes on both sides and can get worse if not managed properly. The treatments that are particularly associated with peripheral neuropathy include bortezomib and thalidomide, whereas other drugs in those respective groups, such as carfilzomib as a proteasome inhibitor and lenalidomide as an immunomodulator, are less associated. It's also important to be aware that even in myeloma, it's not only the myeloma protein which can cause the neuropathy, or the drugs which can cause the neuropathy, as I've already said with bortezomib especially, but also other complications, such as a protein called amyloid, which can be produced by the myeloma, leading to effects on the nerves. Furthermore, other non-myeloma conditions such as diabetes and autoimmune disease, or even carpal tunnel syndrome, can also lead to peripheral neuropathy and exacerbate the symptoms. So what are the symptoms? I've already mentioned that sensory peripheral neuropathy leading to numbness, tickling and prickling, as you can see in the table, and neuropathic pain is the most common type of neuropathy, although pain, thankfully, is less common than numbness and tingling. In particular, bortezomib-associated peripheral neuropathy can be painful. It's really important for all patients to report any change in sensation, and certain things that people can say to us include, my feet feel cold, but they're warm to touch, or I feel like I'm walking on cauliflowers. They increase our awareness that you are having sensory symptoms, or the start of sensory neuropathy symptoms, and may help us to make adjustments to dose of your treatment if required or if severe enough. Neuropathy can also be motor. As I said, it can affect the way you move, leading to muscle weakness, muscle wasting, or cramps. And in conjunction with that weakness, if the gait is disturbed, then there is a risk of falls. Furthermore, as I also already mentioned, it can affect bodily functions, and this can lead to what we call autonomic symptoms, such as, I've already mentioned, blood pressure issues, but also bowel and bladder issues, and also sexual dysfunction. So how do we manage this bortezomib-induced peripheral neuropathy? There is really no known treatment directed at protecting or repairing the nerves. However, it is good to be aware that if there are other reversible causes, such as vitamin B12 deficiency or diabetes, it should be optimally managed to reduce the risk. So we often adjust the dose of bortezomib as the product information tells us to reduce the symptoms. We would educate you as the patient to try to prevent slips and trips and falls. Exercise is good to maintain balance and strength. Some patients have derived benefit from acupuncture, and the other modality here called scrambler therapy is essentially using distracting therapy, such as a TENS machine, to help with coping with, for instance, pain. In terms of managing the pain, certain drugs have a good record of helping, such as a number of antidepressants like amitriptyline, nortriptyline, and duloxetine, whereas pregabalin, being a very highly used agent in neuropathy, has been found to be very useful in bortezomib-induced peripheral neuropathy. So what are the other adverse events or side effects? Well, I've got a table here, but I will only mention a number of them. So for instance, carfilzomib, with the C, stands for cardiopulmonary, but particularly cardiomyopathy. And it's important to measure a patient's heart function before we use carfilzomib to prevent patients from experiencing cardiac impairment, which can worsen their symptoms. Lenalidomide, as I already said, can lead to clotting concerns. But the D stands for diarrhea, and I will have a few slides on that because it's such a common symptom. For monoclonal antibodies, such as daratumumab and lotuzumab, there is a risk of infusion reactions, but we use pre-medication to either mitigate them or prevent them. And then finally, a drug called selinexor on this slide has specific concerns such as hyponatremia, gastrointestinal side effects, and also T standing for thrombocytopenia. And I'll particularly mention that because it does affect quality of life significantly. In this next slide, I particularly want to point out corticosteroids. And the most commonly used corticosteroid is dexamethasone, and I want to pay attention to its effect on increased blood sugars, which is very, very important in patients with underlying diabetes, but even in those who have non-diagnosed diabetes, to ensure that their sugars are checked so that they are well managed. In terms of the metabolic syndrome, we all know that dexamethasone can lead to weight gain as well as fluid retention, and it can also lead to insomnia. So lenalidomide-associated diarrhea is so common, and yet certainly in terms of doctors' talks and seminars, we don't talk about it much, but it's so important because it affects between 40 and 54% of patients on lenalidomide. The chronic diarrhea is particularly challenging, and often at first, when you start on the drug, you don't experience it, but come 18 months or so, it can start. The likely mechanism is something called bile acid malabsorption. Normally, bile acids are released into the part of the small bowel called the duodenum after we eat something with fat in our food. But in this bile acid malabsorption mechanism, these bile acids, which should be reabsorbed into from the gastrointestinal system, is not reabsorbed. So they remain in the bowel, and they can then lead to stools, liquid stools, which are essentially diarrhea, and sometimes more than 3 a day, which can be very troubling. There are other contributing causes which can add to this in a myeloma patient, such as having had radiotherapy. If you've had a transplant from another person, that is an allogeneic transplant, graft versus host disease can also contribute. There is a scan which can be used to diagnose this, but we almost never do it now. It can be done, but is very rarely used or available. So we mainly use our ability to try to improve it and then assess the response to make the diagnosis. It is very important, though, when a myeloma patient who's been on long-term lenalidomide and then develops this diarrhea, even though we think it's most likely due to the lenalidomide, in the appropriate situation, we should try to exclude other causes, such as another malignancy, for instance, by doing a colonoscopy, or exclude infection. So how do we treat bile acid malabsorption? Well, we can use loperamide to reduce the hyperactivity of the bowel. We can restrict the dietary fats because, as I said, bile acids are released as a result of fat ingestion. Or we can use a medicine which is called cholestyramine. What it does is to act as what we call a sequestrant of bile acid by binding to bile acids in the gastrointestinal tract to form a complex which is then excreted in the feces to prevent those bile acids from causing the trouble that I mentioned before. However, it's important to remember that questran or cholestyramine can interact with other medications, and so we would usually advise other medicines being taken an hour before or 4 hours after questran, and it's important for you to check with your doctor as to whether those medications need to be changed in the way that they are taken. Of course, one way when it is of treating this situation is reducing the cause of it, which is the lenalidomide, and that is certainly often done when the diarrhea becomes too difficult to manage. Infection is a really important factor in myeloma and certainly affects quality of life. It's especially common during first-line therapy when the myeloma is highly active or when the myeloma has already been treated with many lines of treatment, such that patients are more susceptible to low blood counts. When the patients are being treated with higher doses and cumulative doses of steroids, which depress the immune system. When a patient is more frail or has kidney impairment. So our advice to our patients is that it's important to know the signs and symptoms of infection and act upon them in a timely way. As you know, we sometimes give preventative antibacterials, but that particularly applies to Respirine that I mentioned before to prevent that particular type of pneumonia, which can be very severe. In general, we tend not to give antibiotics in a preventative way in most situations because we also don't want to breed resistance. Sometimes we use growth factors, called GCSF, to increase the white blood cells. We advise patients to undergo non-live vaccinations to prevent infections such as flu, pneumovax, COVID, Shingrix, and if appropriate, respiratory syncytial virus vaccination. It is also important to mention that household members being vaccinated does help because a lot of flu, for instance, and other respiratory infections are gained by contracted from members in the house. And also food safety in terms of food poisoning and diarrhea, extra caution when one travels, and when gardening to use masks and gloves. Then specifically on steroid side effects, I've mentioned the key ones here in yellow, the effects on mood, on cataracts, on sleep disturbance, already mentioned infections, muscle weakness, blood sugars, thinning of the skin, heartburn, for which we often use antacids, as well as high blood pressure and fluid retention. So to manage these effects, we often have to use dose reductions. If not, sometimes dividing the dose or tapering the dose actually relieves the side effects. I already mentioned using antacids, which is what we mean by the proton pump inhibitor here, to help with sleep, sometimes using sleeping tablets, but other non-pharmacological ways of helping sleep as well as diuretics for fluid retention. There are many non-pharmacological ways to try to relieve the steroid side effects, such as relaxation, modifying diet and exercise. And I think overall experience helps. If you're starting steroids for the first time, talking to your doctors, but also with in a support group as to other people's experience helps. But also learning within yourself the pattern and pacing and planning of when you will have the side effects. Sometimes using a symptom journal can help you know and try to figure out how best to especially use non-pharmacological remedies such as exercise to try to mitigate the effects. There are many supportive measures which we also use to support you, which are within the medical paradigm, such as bisphosphonates to prevent fractures and build up bone, blood products, growth factors, antivirals such as prevention of shingles, Respirine I've mentioned quite a few times, using intravenous immunoglobulin, and now there is a subcutaneous option to prevent infections are important, vaccinations, radiotherapy to relieve painful lesions in the bone, antiplatelet agents and anticoagulants to prevent clotting. I'm getting to the end of my talk now, so I just wanted to, as I mentioned, look at two particular drugs which can affect quality of life, and by using appropriate measures, this can be really mitigating and helpful. So the first one is selinexor, where Professor King, as you can see here, actually constructed a document to indicate how to use a dual antiemetic, meaning two anti-nauseants to assist with coping with the nausea. And this includes an ondansetron regime, as well as another medication called olanzapine. There's also a combination anti-nauseant, which is called Akynzeo, which we as a group are using really very commonly now with selinexor. And sometimes it is necessary to seek drug committee approval for it at the beginning. But as the understanding of selinexor has increased and its classification, the access is now much easier. We need to maintain hydration because it can lead to low sodium in the selinexor as a side effect. We tell people to improve to take salty snacks as well as increase their calories, sometimes by consulting a dietitian. And the further slide that I wanted to mention here is belantamab, which we don't have standard of care yet, but in the hope that it will become available. The main concern that a lot of patients and doctors have is the effects on the eyes. And I just want to mention that we, as your myeloma doctors, have a very clear understanding of how often we should get your eyes checked, and how we are hoping that we can start a system whereby patients can see optometrists together with an ophthalmologist as a kind of hub and spoke model to be able to manage these side effects to preserve your quality of your vision and the ocular symptoms. Eye drops and dose adjustments of belantamab are very important. And as a matter of fact, with the trials and additional work subsequent to the trials, we actually know that the starting dose can be reduced with equal efficacy and without as severe side effects. Finally, I think it's important to basically promote a healthy lifestyle to improve quality of life. Here I've got some suggestions to maintain a good nutritional status, to make sleep a priority, not to smoke, to understand what causes stress and look at ways of minimizing it, and therefore to use support services such as counselors and clinical psychologists. And also, I've already mentioned the benefit of exercise because it's increasingly recognized as having wide-reaching health benefits in cancer and beyond. So now I've come to the end of my talk, and I'd just like to acknowledge my team. Importantly, Professor Tracy King, who's standing in front of me in the photograph on the top, but all my colleagues, both in the research unit and in our clinical unit. And I particularly want to thank Myeloma Australia for inviting me to speak. Thank you.